Second Annual Olfactory Neuroblastoma Patient Education Meeting, February 2021.
The patient's view. I even asked a few of my patients this week what they would want to hear. They made sure that I talk about staging, because they said everybody really wants to know what stage they have. So I did try to think about it, and the first thing to know is that esthesioneuroblastoma is a very rare cancer. And first of all, cancers in the nasal cavity and the perineal sinus is only 3% of head and neck cancers, and of that, 3 to 5% are esthesioneuroblastomas. So it's hard to find people from the right specialty who know how to take care of this and have seen this before. And so that's some of what I want to keep in mind. The disease does affect across all ages. So we do see this in children sometimes. There's predominance between 40 to 60 to 70 years old, but does across the lifespan. And what is it? So these are tumors of the olfactory tract. And the reason this is important is that one of the things we think about is where these tumors go. So these cells probably start in the lining of the nerves of the olfactory tract, and they can happen anywhere that the nerves are. And I don't know if you can see my pointer that's showing, but basically these little fibers come through the bone of the skull into the mucosa, and they can extend all the way down the mucosa, the septum, or the various pieces of anatomy in the nose. But also, because there are these pre-existing holes in the bone, they can extend up through the bone. And so passing through the bone of the skull may not have the same significance that, say, another cancer does. So squamous cell cancer, something like that. When that goes through the bone, that usually means that it's attained the genetic ability to eat bone and eat its way through it. Whereas this tumor sort of has a pathway or a highway, as you'll say, that goes right through the skull base. So as a result, we more frequently see it going straight through the bone to the other side, and we have to look there. But it may not have the same dire consequence as some of these other cancers when we do find it there. Patients usually present with symptoms of late stage. It's usually mass effects, so they may lose their smell, have a sense of obstruction and nasal breathing. Sometimes we get bloody noses. Late stages would be swelling of the eye or the face, or loss of vision, change in the vision. Risk factors. How did I get this? We don't really have any known risk factors for this cancer. We just, because of the rarity, we haven't really developed that type of data. So I think about, if you've just been diagnosed or you're dealing with this, what checklist would I form? So we've kind of covered what it is. Where do you go for treatment? And what are the important steps once you get there? So the first thing I would say is make sure you confirm this is esthesioneuroblastoma, and I'll go over that a little more. Then if you see a physician who really knows what they're doing, they're going to work up the side of the lesion, not just in the head, but your whole body, to make sure that this hasn't spread, and then consider the treatment options. And then, of course, we want to know how successful the treatment options are. So who treats esthesioneuroblastoma? This is probably one of the most confusing things for a patient, even for some physicians. There are a lot of skull-based centers out there, and that may be an appropriate place to start, but sometimes skull-based refers to the disease of the ear. Sometimes it refers to the nose. There are a lot of rhinologists and rhinology practitioners, those are doctors who work on diseases of the nose, who've taken this on and work in conjunction with other teams. And then, of course, head and neck oncology practices, such as the one I am, where I practice, would be ideal places to work on it. But not every head and neck practitioner works on this type of problem. And so there's certainly some cancer centers out there, but not all of them are specialized. I want you to know that esthesioneuroblastoma requires a multidisciplinary team, and that is due to the subspecialized interest involved in terms of the anatomy and the disease process. And so I just kind of want to show you, this is what the multidisciplinary team at UCSF looks like. We have the otolaryngologist, head and neck surgeon. We also have some people on the rhinology side who work endoscopically. But this is not always a endoscopically approached tumor. Sometimes we need more traditional head and neck cancer approaches, and it's good to have a team that knows how to do both of those. We work very closely with our neurologic surgery team, radiation oncology, medical oncology. If you're going to have radiation to this area, you have to see a dental oncologist or a dentist, but traditionally somebody who knows the issues with radiation. So we have a dental oncology team on site. And then, of course, you need to have experienced radiologists who know how to look at this, and pathologists who know how to diagnose this. And then, of course, reconstructive surgery. I think Dr. McKean's going to talk about that. And then we have multiple auxiliary services. We have the oculoplastic team because it's very close to the eyes. Interventional radiology, nutrition, symptoms management deals with issues such as pain and other issues like psycho-oncology, dealing with the stress of this disease. So really a team approach is very necessary for tumors in this area. So why do I say you need an experienced pathologist? These tumors are considered small, round, blue cell tumors. And this is just a list of the small cell blue round cell tumors. Sorry, I don't mean to be doing that. And are my slides advancing? Huh.
Yeah, they were advancing okay. We were seeing a smaller version of the slides, but
oh, I'm sorry. I thought it was going. Well, it's a beautiful talk I have for you here.
We could see them now. We can see them in a
okay. Well, I did something with a small blue cell tumor, but that slide I was showing you really is the list of variants and multiple tests, and it really takes a skilled person to sort out between those which exact tumor this is. And it needs to be somebody who's seen multiple times the different variants and understands to look for all those little signs. But you can see there's a lot of factors they have to look for. It's very important though to get the correct diagnosis. And so hopefully you're seeing my big slide now. So this is at the end of the day, Estesian neuroblastoma is a neuroendocrine tumor because it comes from these cells that are surrounding the olfactory tract. And there are other tumors. There's sinonasal undifferentiated cancer, neuroendocrine cancer, and small cell cancer. And they have different outcomes. So this is a survival curve. So if we looked at 120 months after the diagnosis, that'd be about 10 years. You see that for Estesian neuroblastoma, almost 80% of patients are still doing well and alive. And the survival rates change for some of these other diagnoses. So getting the diagnosis is important, as well as the treatment plan would be very different. And it's hard to read the literature because a lot of older studies incorporate these three tumor cells into their data because these are recently described, well, maybe not so recently, but 1986 for the undifferentiated carcinoma, and neuroendocrine was described in 1982, and it's taken a while to get those into the literature. So once you have the diagnosis, workup, typically we want to know exactly what the extent of spread is in the region of the tumor, so we get high quality MRI scan. This will look at things like soft tissue. It can show us water and infiltration into the brain. This is a cyst extending intracranially, and it can show us a lot of information that would help us predict if we can get this out surgically and how far it has gone. We also typically get CT scans that show us the bone, the white here is the bone, and you can see there's a thin line between the eye and the tumor here. So this can be very helpful in determining the extent of disease. In addition to the local spread, we need to look for disease spread to the neck or to the rest of the body. So typically we get a PET scan or a PET CT scan at my institution. At a minimal, you need to have imaging of the neck and CT of the chest to just look for the most common sites of spread. What about staging? So there are 3 anatomic stages, and I'm told that this is where people really start to focus, but the issue is none of them are very good. They give us a general guideline. The most commonly used and referenced one still is the Kadish system, which was developed back in 1976 by Dr. Kadish, my home institution in Boston University. And interestingly, he went on to become an emergency room doctor, a little bit of a tidbit, and had no idea that this was such a used test. At any rate, the other thing that we think might be important is the grade of the tumor, but none of them are really specific. So this is looking case by case to decide what's appropriate for you. And I'll give you an example. The Kadish system is nasal cavity alone is a small a. B, it can extend to the paranasal sinus or just up to the skull base and would still be a Kadish B. So C extends outside the paranasal sinus. So any extension into the brain would be a Kadish C, whether it's just a little bit or whether it's really extensive. And so we don't really have a way to adequately describe those. Treatment options. So surgery certainly is considered one of the mainstays for management of this. Small tumors may be handled with surgery just alone or with radiation surgery. When we have larger or extensive tumors or positive margins at our institution, we'll introduce chemotherapy. Surgery can be performed endoscopically, that's through the nose, and usually we work together with neurosurgery. Once we get up to the skull base, the neurosurgeon will come in and we'll take down that part that's intracranially. And endoscopic assisted, we sometimes use the endoscope to lessen the amount of surgery we do for what we call open surgery. So open surgery would be anytime we need to make excisions on the face or on the skull and to get access. So this is just an endoscopic view. We look into the nose. This is what the inside of the nose looks like. We're missing the midline tissue. But you can see we have to work on all this tissue here and create enough room to work with our instrument. So typically we have to remove all this tissue to get up to the skull base. And I apologize, this is too much for anybody. But this is what the defect looks like at the end of the case. We have the orbits on the side, kind of stripped and clean. And we've removed the tissue at the top, exposing the brain. We see nice, clean tissue up here. And if we get with the endoscope, we think we get a magnified view. This is just peeling tissue off. We see it comes very nicely off the orbit. And can send this in layers to the pathologist at the time of surgery to see if the margins are clear or if they're involved. With smaller tumors, the endoscope now sometimes we can do just a unilateral tumor to try to save the smell, because if we're removing the cells of the olfactory tract, then obviously the smell will be affected. It sometimes doesn't work, sometimes it does, but sometimes we still have to do non-endoscopic approaches. And so we can have these very large, extensive tumors. This would be a typical excision that we would use on the scalp and to kind of open the brain, the craniotomy there. So this is just looking at UCSF experience. These are the trends from 1970, all open approaches, the red and the blue, We see here 2006 or so, I introduced endoscopy to my practice, and the majority of tumors are now handled endoscopically. And so just to say the endoscopic approach, if you look at the studies, it says that, the endoscopic has much better survival. However, that's probably because the tumor selection is what can be done endoscopically. But we do see that we have reduced hospitalization stay of about 3.5 days to 7 days. The key is that you have to remove all the tumor. There is a risk of spread to the neck. About 8 to 10 people present with neck disease, and another 10 to 15 develop late neck disease about a year or two afterwards or at some point. I think it's my last slide here. So survival, 5-year survival for anesthesia is about 80%. 10 years, about 67%. And we're looking at our series here since 1972. We found about 17% developed neck disease. Average time is 47 months. That's a little over 4 years, 5 years. 17% developed recurrence, 140 months. That's 10 years out. And distant disease happened about a median time, about 120 months was about 10 years. So the other thing we looked at is that we found a lot of these patients we were able to treat and get extended cure as well. So 5-year survival after recurrence was about 50%, and we have some very long-term survivors after recurrence as well. So my take-home points is that diagnosis and treatment is best done at an experienced center. So it's very important. The treatment really is adequate surgery. It means getting all the tumor out when you can. That's one of the most important determinants of success. And radiation for most tumors, and of course we'll hear about chemotherapy, and long-term surveillance is needed. I think with that, I'm done. I know I packed a lot in for 10 minutes. I'm happy to talk afterwards and answer your questions. So thank you, Niall, for letting me be a part of this. I think it's really a good work you're doing here.
Of course. Thank you so much, Dr. Elsa. That was a fantastic talk, and thanks for introducing some of the anatomy and other areas that you addressed this morning. Really appreciate your thoughts and your comments. And I think we will hold questions until after all the physicians are done speaking. There will be plenty of time to ask questions of them in the breakout sessions. It'll be right after the physician talks this morning. So again, thank you so much, everyone, for joining us. And our next speaker is Dr. Michael Link, and I'll let him introduce himself a little bit as well. Thank you.
Can you see my slides okay?
We see your slides. It's the version where the presenter version, though, so we can see your next up slide as well.
Oh, shoot. Okay, let me try. How about now? Is it any better now?
Still the same.
Still the same.
I stopped looking at my slides and lowered it, and then that's when the screen went to the big screen.
Okay, let me try. So, So you're seeing the display where you see the next slide in line, huh?
Yeah, but I mean, it's okay if we can't.
If I can't figure out how to fix it, huh? Um, how's that? Any better?
Oh, yeah, perfect. Yeah, they got it.
Okay, let me go with that. You can hear me and see me and see my slides.
Yes.
I just want to say thanks so much, Dr. London, for organizing this. This is indeed a rare disease, and as Ivan so well discussed, it's a multidisciplinary approach to treat this type of cancer, and I'm really honored to be included in the panel today. I'm a neurosurgeon by training here at Mayo Clinic in Rochester, Minnesota, which is a very cold place to be from. I also have a joint appointment in the Department of Otolaryngology because I spend so much of my time dealing with cancers just like this. I don't have any financial disclosures, and obviously I was asked to discuss perspective from a neurosurgeon standpoint, and perspective is very important, obviously. So if you, depending on how you look at something, you might come up with a completely different answer. And it's very important, I think, to take into account the perspective of my colleagues in other specialties. And Ivan listed all those various specialties that we get involved with, as well as the perspective of the patient, obviously, who has to go through extensive treatment once the diagnosis is made. And when I see a patient with a craniofacial mass that's suspicious for an esthesioneuroblastoma, the first thing I always ask is, do we have the diagnosis correct? And if this is a biopsy-confirmed olfactory neuroblastoma or esthesioneuroblastoma, two names for exactly the same thing, the first thing I kind of look at is, can I remove the tumor and achieve negative margins? And what I mean by that is when we get done with the operation and then we biopsy everywhere around where the tumor was, and we send those biopsies to the pathologist, they can do what's called a frozen section, where they can look at them immediately and tell us, do they still see cancer or not? The goal of our surgery is at the end of the operation, wherever we biopsy and the pathologist looks, they say, we don't see any residual cancer. And of course, what we have to consider is what operation is required to achieve that. So sometimes we can work entirely through the nose with no external incisions whatsoever, no incisions on the scalp, no incisions on the face, no haircut required. Sometimes, and I'll show you some cases, we do have to make an opening in the skull to make sure we can achieve those negative margins. And then a big part of what I get involved in, and I think Aaron is going to talk about more, so I won't really discuss too much, is what do we do to reconstruct the skull base? It turns out in all of us, the barrier between the brain cavity and the nose cavity is very thin. And that's one of the strategies by which we have this sense of smell. And then, of course, we have to think about what additional treatments are going to become necessary besides surgery. So we have to think about if somebody's going to have radiation, that is going to affect the surgery that we did. What's the timing to start the radiation, and do we have a robust enough repair that we're not going to get into trouble down the road? So this would be a very common thing that I would see in my clinic as a patient would come in who, as Ivan mentioned, maybe had loss of their sense of smell, obstruction of their breathing through their nose, a nosebleed, some pain, and they get imaged, and sure enough, they have this mass that's going here down into the nose and then here up into the brain. This would be the right eye and the left eye. And as we would look at this, we would say, well, here's the eye muscles here, these white things. Those do not look involved. The optic nerve does not look involved. Probably the lining of the eye is involved, but the other critical structures aren't. So this would be a case that then also we look and say, well, how far back does it go and we see there's a little bit of an area where the tumor does not appear to be involving before you get back to where the optic nerves, the nerves which give vision, enter, and where the pituitary gland sits. So this is a case where we would say, well, we can do an operation and take this tumor out and expect to get negative margins at the end of the surgery. And this is just an anatomic picture to kind of better demonstrate what I'm speaking about. So this is a model of the head as if the brain was not there, and we're looking down at the base of the skull from above. So this is the front of the head and the sides of the head. And this is actually a model of the smelling nerves that come here to what we call the olfactory bulbs. And then the actual smelling nerves go down into the nose, which is sitting down below. And this is what it looks like when we think about the anatomy when we're doing an operation. So what we're going to have to do is take out this bone. So we're now going to communicate this brain cavity down with the nose cavity. And then this is the structures in the eye. These are those eye muscles that I mentioned, and some of the nerves that go to those muscles and give sensation to the forehead, and so on. And these are the optic nerves back here. So when we get done, we're going to have this big opening from the brain cavity down into the nose cavity. And the problem with that is the brain and spine float, actually. They're surrounded by spinal fluid. We're constantly making spinal fluid and resorbing spinal fluid, so we never run out. But at the end, we don't want that spinal fluid to leak down and be a persistent problem, because if spinal fluid can leak down into the nose, potentially bacteria could swim upstream and cause an infection in the brain or a meningitis. So at the end of the operation, we want to have some of this covering of the brain called the dura-left that we can sew some type of graft to make a nice barrier between the brain cavity and the nose cavity again. And there's a variety of tissues that we use. It turns out, as human beings, we've got a lot of spare parts, and we utilize that in surgeries such as this. One of the spare parts I really like to use is the covering of one of the leg muscles called the fascia lata. So a lot of the patients with large tumors that I operate on also end up with an incision on their leg. And I always warn them ahead of time that we meant to do that. We didn't get confused and replace their hip or something like that. But that fascia lata is just like the dura, or the covering of the brain, so we can borrow it from the leg and then sew it in here to replace the covering of the brain. There's a lining to the scalp called the pericranium that sometimes we use as well, or there's some lining to the chewing muscles on the side of the head that we can borrow. And the whole goal is to make a nice barrier now between the brain and the nose cavity. This is an example of a patient I saw a few years ago, only 24 years old. Pretty typical looking picture for an esthesioneuroblastoma, but the concern is this tumor was very much involving the right eye here. And we thought if we were going to do an operation and take all the tumor out to achieve those negative margins, which we think are critical to achieving the best result so the cancer does not come back, that we'd have to take the right eye out also. And obviously we don't want to do that. So sometimes there's a good role for chemotherapy. So rather than take the patient directly to the operating room, we treated him with 3 rounds of chemotherapy, and you can see the tumor shrunk really quite nicely and came away from the eye muscle here. And then we were able to do the operation and take the tumor out and get negative margins, but did not have to take the eye out. This is just an example of what can happen either right after surgery or sometimes many years down the road if that repair, that barrier between the brain cavity and the nose cavity breaks down. So this is a patient that's 6 years out from surgery. And what had happened here, this is looking at the head from the side. The repair had broken down many years after the patient had surgery, chemotherapy, and radiation therapy. and all the spinal fluid leaked out. So everything on these images that looks black is actually air. So when the spinal fluid leaks out, air can get in. So this is a patient, obviously, we took urgently back to the operating room to reconstruct this barrier. And ultimately, the patient did just fine, but it also emphasizes the need for long-term follow-up. Sometimes these tumors grow very, very large before they're discovered and really require extensive neurosurgical involvement. This is one that didn't have a really huge component down in the nose, but had a very large component up into the brain, almost to the center of the brain. But we were able to take that out with surgery and reconstruct things. And this is now 5 years following that surgery and radiation with no signs of tumor recurrence. This is an unfortunate young man that I took care of just 2 weeks ago. He actually presented with severe bilateral visual loss and one of the largest esthesioneuroblastoma I've ever seen. This is looking at it. You can see both orbits are involved, a lot of brain involvement. And this is a case where I know I can't get negative margins, but the patient has such a large tumor, so much mass effect, that I felt we have to do the surgery to decompress the brain or this tumor was going to prove fatal in short order. And so we took the tumor out, did the reconstruction, and now we're going to have to really rely on radiation and chemotherapy, as our colleagues will talk to us about shortly, to provide long-term tumor control. One of the other ways I get involved as a neurosurgeon is I also do radiosurgery, which is a way for talking about single fraction, one dose, very focal radiation. The device that we use here at Mayo Clinic is the Gamma knife, which is not a knife, it's just a way to deliver focused radiation. And that works very good for some focal recurrences of these tumors. So I just want to say, I want to emphasize what Ivan talked about, that this is absolutely a team approach. Neurosurgeons, otorhinolaryngologists, neuropathologists, medical and radiation oncologists, ophthalmologists, physical and occupational therapists. The follow-up is very important. Somebody needs to be the captain of the ship, and here at Mayo Clinic, we kind of do that jointly, I would say, I think much to the benefit of our patients. So that's all I wanted to say from a neurosurgeon's perspective. Thank you again, Niall, for the wonderful invitation. I will stop there and I will stop sharing.
Thank you so much, Dr. Link, for a wonderful, wonderful talk. Really enjoyed that. Our next speaker is Dr. Erin McKean. She's also a head and neck surgeon, but she's going to talk to us a little bit about the reconstructive perspective. I think you're muted still, Erin. We saw your slides.
I thought I would be slick and have the slides up and then unmute. Hopefully you see the full screen here, right?
Yeah, it looks perfect.
Awesome, thank you. So I'm from the University of Michigan, and I want to thank my colleagues, Dr. El-Sayed and Dr. Link, who did a great job of doing two things for me. Number one, laying the background, and I'm going to reiterate some of their same points. But number two, already breaking the ice with, oops, here we go, getting a request. Here we go. Also breaking the ice with perhaps slightly graphic photos that we as surgeons are used to, but I wasn't sure how much you want to see as patients. So my only disclosure is that I did run my slides by my 7-year-old and she approved. But full caveat, her mom's a head and neck surgeon and her dad's a brain surgeon. So there are a few photos here that may be difficult. Okay, someone has asked for ability to annotate. I'm not sure if that's going to work. Here we go. So again, you heard about the importance of the team approach, and even when it comes to reconstruction, it is most important. Number one, I just want to reiterate, reconstruction is important, and from a patient's perspective, you might be worried about what is this going to look like, what's going to be, what's happening to me when you're doing this operation. And I just want to focus on the fact that number one, most important thing is to get the cancer out completely. Because remember, if we leave cancer in, that eventually is going to grow and cause a problem as well. So in most cases, very rare cases where we might not focus on getting the cancer out completely, but in most cases, that's the priority. And we're going to take into account the location of the tumor, as you heard from my colleagues, as well as how invasive, how aggressive, or we call that the grade, how it looks under the microscope and how it behaves aggressively. Those things are going to determine the best approach to get out the cancer completely, along with your own unique factors. And in doing so, for the best reconstruction, we need to do the best resection. And in terms of that, if you go and do get a resection outside, or where they take the tumor outside and need to come back in for a revision, it's not the end of the world, but sometimes when we're doing revision operations to get the cancer out, some of our reconstructive options are we call burned. We can't use them anymore. So for example, if somebody thinks this might be just polyps in the nose and you get a septoplasty done at the same time, that could leave a hole in the septum or the middle part of the nose, or it could leave a lack of an oncologic barrier or a good cancer barrier to spread of disease, so that when we go to try to do it, say endoscopically, we don't have an option of a flap. We'll talk about what that means. We don't have that option to use now. And so again, I just say, for rare diseases, the team is important and a high volume experience center is important. So we do the right surgery up front with the right reconstruction up front, where your surgeons are thinking about the important nerves, the important blood supply, what we can and cannot spare, so we know how to best reconstruct. And in being at that high volume center, you're in a place that has a big toolkit of all sorts of ways to reconstruct. So you saw some pictures from my colleagues. These are two very different esthesioneuroblastoma cases. So in one case here, we have to talk about how to manage the orbit. And I will also tell you, in this case, there was intracranial involvement in the brain cavity with extension along the dura. So the lining of the brain was involved. This is a big defect that we're going to have to reconstruct. And we heard about having to consider, is this invading into the eye or just pushing into the eye? How do we reconstruct this versus a patient who comes with the tumor primarily in the nose, and we're going to be able to manage this primarily endoscopically? Our goals in reconstruction are to separate the sinuses from the brain. Obviously, if fluid from around the brain or CSF can get out, snot can get in, that can cause deadly meningitis or encephalitis. We don't want that. We need to separate those two spaces. We want to restore and retain function if we can. And sometimes we can, sometimes we can't, but we can do a good job of trying to restore or improve function in that case. And then cosmesis is important too, because we want things to go back to looking as normal as we possibly can. So your surgeon may talk to you in reconstruction about grafts, flaps, and free flaps. What are these? These are just tissue that we can take from your body or from, so we have allograft, other humans, your own body, or synthetic material. Grafts are materials that don't have its own blood supply, that basically we put it on as a patch graft. It sits on or is sewn on as a repair. Flaps can be taken from nearby, and we call those rotational flaps. It is most common these days when we're doing an endoscopic resection to do a nasoseptal flap, or take mucous membrane from inside the nose with its own good blood supply. This is what makes a flap. It has blood supply. It's attached to something, either the tissue around it or its own blood vessel that has a name. And we can use those flaps of tissue connected and rotating them to cover and restore separation between the brain and the sinuses. So a common one is the nasoseptal flap from inside the nose. We can use all sorts of different things. And Dr. Link talked about the pericranium, or that's that tissue that our scalp slides on. If you pull your scalp around, the pericranium is an amazing gift to us underneath the scalp that we can rotate without seeing it on the outside into your nose. This picture down below is a patient who had a prior septoplasty, had an endoscopic resection, but I didn't have great tissue from inside her nose to use. So I made small incisions on the top of the head, and tunneled it underneath the scalp, made incisions in this nasal bone from the inside of her nose, inside out, tunneled that tissue in the nose. Here you see it pulled out through the nose, and then I'm going to tuck it back in to line the base of the skull. We can also take free flaps. That means like a transplant from your own body, essentially. We can take them from all over the place, your forearm, your thigh, your abdomen, shoulder blades, your legs, to take like tissue with its own blood supply. So an artery and nerve, or artery and vein, sorry, and hook it up to get it reconstructed. This is real common to use a free flap when somebody has had radiation and prior surgery, and we need to bring in new tissue, or an orbital exenteration where we remove the eye. So from a patient perspective, I mean, those are the things the surgeons need to think about. What do you need to think about? How can you help us, or what things can hurt us? So if you can stop smoking, we know that hurts our flap grafts in healing. If you can get your diabetes under control and partner with your primary care doctor and team to do that. Nutrition, there's no particular cancer diet per se, but healthy nutrition, good diet is very important for healing. Age, there's nothing you can do about, but more for framing, so you know that the older we get, the less well we heal, unfortunately, and we have to take that into account. Certain medications can impair your healing, radiation, of course, and we may screen you with labs to look for things like thyroid dysfunction or pituitary dysfunction, which, by the way, can happen after radiation or treatment to the skull base. And then infection. We try to avoid that at all costs. And you can imagine when we're operating inside your sinuses where there's snot and crusty boogers that can build up, we need to get that taken care of. We need to avoid that so infection doesn't break down our reconstruction. People are often curious about post-op appearance. This patient on the left had an endoscopic resection. This is the patient who had a tunneled pericranium. There is a little bit of fullness here where I tunneled that tissue from the scalp inside the nose. I'm going to show another picture of this patient later on. On the right-hand side is a patient that's after resection and radiation. You can see an incision that's covered well by her hair, but you know, if she's in water or parts it the right way, you can still see the incision. And sometimes we lose a little hair permanently around the incision. We call that alopecia. But overall, a good cosmetic result. Even in this case, with an open approach, that the patients had a craniotomy and had these bones over the eye removed and replated. So a good result. There we go. Did I skip? There we go. Just prosthetics were brought up. Sometimes we do have to remove the eye. And sometimes we have to remove the upper jaw in extensive tumors. Very rarely do we need to remove any portion of the external nose. These things can be reconstructed in a way with, sorry, I'm getting a few requests for annotation here, but they can be reconstructed with a free flap, but it's not always perfect. I want to show you that if you have a good team in a high volume center, we have anaplastologists who we work with. This patient had an orbital exenteration of his right eye. Underneath this is a stick-on eye by a very artistic, skilled anaplastologist that he wears for photos or going out in public. It does not move. When we remove the entire eye, you can't restore mobility, but you can restore some appearance in some cases. And these are the choices and trade-offs we discuss with our patients. There we go. Here's a little more graphic. Delayed complications can happen, and we think about these ahead of time as we're reconstructing osteoradionecrosis. You may hear about that next, so I'm not going to spend a lot of time, but briefly, when craniotomy bones or bones that have been devascularized, we make cuts in surgery and then they get radiated, they can be more prone to breaking down in the long term, and you can lose the bone flap or that bone tissue that was opened, and it can get infected if it erodes into sinuses and cause a lot of problems. This is a challenge to reconstruct, and we need to use free flaps. We recommend close long-term follow-up to avoid a situation like this if we can. Other things that can happen are collapse of the nose And we can reconstruct that with a rhinoplasty. I am showing a patient who had the opposite result, some fullness over the nose and a pre-existing hump on the nose. As long as I was going to go in and fix this and make it look better, I did a delayed rhinoplasty a couple years down the road, and she was very happy with the appearance of that down the road. So we can do reconstructive and functional or cosmetic and functional reconstruction down the road. Same thing with open approaches. Sometimes we get a little bit of hollowing here, temporal hollowing. We can add fat grafts. We can do a second operation with a synthetic graft to put in there to make that bulked out. Finally, delayed complications. It's not really reconstructive, but hypopituitarism can happen. The pituitary is the main hormone gland of the body, and that can be impacted by radiation. And when that is impacted, it can cause all kinds of problems for you, and it can cause tissue to break down and need further reconstruction down the road if you have delayed complications. So I bring that up only because I think it's an important point we don't talk about, the long-term follow-up, watching your general status and your pituitary function, your thyroid function, to make sure things stay good over time. Those are important. That is a lot to go through in a short time. The take-home points: have a team. I'm from Michigan. I don't know where you all are from. If there are any Ohio State people out there, sorry. But as Bo Schembechler said, the team, the team, the team. Be sure you're in experienced hands. Thank you.
Thanks so much, Dr. McKean. That was fantastic. I did my fellowship at Ohio State, but we can still be friends.
I did slightly know that. I'll lead in for our next
From Ohio
speaker too.
State, so.
Yeah.
Yeah, Ohio State is coming right next. Can you guys see my screen?
Yes, looks great, Duke. Thank you.
Great. So thank you, Niall, for organizing this, Dr. London, and for the opportunity to give this talk. I also had the pleasure of working with Dr. London for a year and continue to collaborate with him. The speakers before me did a great job, so I'm going to fly through a few slides, especially the introductory ones. My conflicts of interest is I get research grants from some of these companies, and I also teach, but nothing pertaining to this talk specifically. So as the team has said, it's really, I mean, as the folks on this panel have said, it's really the team that matters. The patient has to be at the center of this team, and it's the most important component. But we have skull-based surgeons, we have radiation oncologists, radiologists, medical oncologists, ophthalmologists, endocrinologists, and then also there's a research component. And it's this link between all these folks in an appropriate way that really provide good outcomes for our patients. And that's that communication that is key. At Ohio State, we have a tumor board specifically for skull-based patients where we discuss with all of our colleagues. And this is something that helps our patients. One of my favorite, I guess someone will have to teach me, but I think it's a Yiddish word, we kibbutz, which I think is a lovely way of saying that, we really get together and we try to talk about all of our patients so that we get the best outcome possible. And this is true for all of our panelists today and a lot of the centers of excellence. So radiation. So what kind of radiations do we have? What do we worry about? And so people are going to ask these questions about protons and IMRT and BMAT, gamma knife and LINAC radiosurgery. The last part, LINAC radiosurgery is more for specific small targeted areas, but really what we want to talk about today are for protons and advanced photon planning. So what's the advantage? Well, I'll talk a little bit about protons specifically in terms of esthesioneuroblastoma, but in terms of aesthesio, when we think about lymph nodes and treatment, we really have to be comprehensive. And that comprehensive notion means that we're not only treating, where anatomically our surgical colleagues showed us specifically where we're going, behind the nose in this area, but we also have to worry about the highway that these lymph nodes, that this cancer is like to travel. And so we think about bilateral necks. And when we do something comprehensive like this, it's a question about if proton is really going to be helpful, but it can be, and I think it's something important to think about. And this is a busy slide, and I want to spend some time on this because the advantage of the protons, and if you can follow these dotted blue where it says proton beam under here, what's interesting is if you see down at the bottom on the x-axis, we talk about deep tissues. Well, in protons, a lot of these deep tissues don't get any dose. This area right here is referred to as the integral dose. So if you think about in this area, these deep tissues, maybe we have some vision apparatus, so the optic nerves and things that allow us to functionally see. Well, protons can potentially benefit us in providing that kind of advantage, which wouldn't be an advantage with photons because, as you can see, photons enter the skin and they come down and they still have some integral dose. So the advantage of protons is to get that dose minimized. And so what you can see here is a proton treatment, and this is in the oropharynx, just is the difference. And so protons, we can avoid some of this dose to normal tissue, and especially in our pediatric cases or our younger adults, this can be very, very important. And so, for example, what we worry about in esthesioneuroblastoma is the dose to the brainstem. And if we look, I'm going to show this picture. If we look here, if my dose to the brainstem cannot exceed 60 gray, with protons, which is the bottom portion here, I can get doses to 70 gray or even higher while I spare the normal tissue. Whereas, so I can get up to 95% of the dose. Whereas in photons at the top here, I will not be able to do that. And that can cause, in turn, some difficulty. And so if there's gross residual disease and we're trying to spare normal tissue, perhaps protons could be an interesting avenue for better outcomes. So what do we worry about? Well, we worry about normal tissue, brainstem and spine, eyes, lens, optic nerve. I didn't put it here, but pituitary, just like was discussed. So the side effects, so in our clinics, in my clinic specifically, I always make sure that the patient is seeing an endocrinologist so they can check their hormone status before treatment and after treatment. The same thing with an ophthalmologist so that they can make sure they see the ophthalmologist before treatment and after treatment to see. And then in rare cases, depending on the dose, we can worry about osteoradionecrosis or brain necrosis, meaning the tissue starts to break down. And this is why the team is so crucial, because this is where we would need our surgical colleagues to help us. We have some medications, but to be very frank, some of these medications do work for some patients, but they do not work for others. And sometimes we think about hyperbaric oxygen treatments and so forth. So I wanted to talk about a case so that you guys get to see. This is a patient that I treated, and he had a high-grade Hymes, esthesioneuroblastoma. It was cottage C. So we talked about the staging and so forth before, but I just wanted to show you. So this is an MRI and a PET scan, and Dr. Crow, who leads our skull-based team, has published some work where PET scans can also help differentiate some of these cancers, like the sinonasal undifferentiated carcinomas versus the esthesioneuroblastoma, just as an added tool, if you will. But we use PET scans as well. And these are, I'm not going to spend time here, but here's the staging components. This is what our pathologists look under the microscope to see. And, we had a patient who had grade 4 Hymes and cottage C. And so in this scenario, we at Ohio State will treat the lymph nodes as well. And we have data to show that if you treat E&I here, means elective nodal irradiation, but you can see that, it's trending towards significance. But if you treat electively, the opportunity of recurrence at 10 years drops significantly. And the risk for neck disease is up to 25%. So this is very important. And what do we treat? Well, sometimes we treat thoroughly down to the bottom of the clavicles. And that's usually when, in our case at least, when we have lymph nodes in the neck to begin with. But you can stop all the way, we usually in an elective nodal will stop around level 3. And that'll change between radiation doc and radiation doc. So when this happens, you're thinking about different side effects. You're thinking about swallowing side effects in the acute, meaning during the treatment. You're thinking about skin changes, mouth sores, potentially taste changes, dry mouth. All of these become important to our patients. And so this is a case of one of our patients where we treated all the way down to the neck. And you can see in the side effect here, we treated the skull base and we went all the way down to the neck because this patient had lymph nodes. And so because they had lymph nodes, we went with the red dose, with the red marking. We went up to 60 gray, and then the blue down here is a lower dose, the 54 gray. And this is where my son teases me quite a bit because he likes to play paint on the computer. And this is what I do too. I play paint, but I play paint on CAT scans and MRIs and PET scans. And I just like to call it educated paint so that my 6-year-old doesn't get the idea that he can do this too. But at Ohio State, we were able to look at our experience where we had 39 patients with full information. And this is just the patient demographics, but it's just important to break it down. The grade still was important. So you can see the overall survival numbers. If you were low grade, you did much better than if you were high grade. So at 10 years, you did better by 50%. If you looked at the stage, this cottage stage, you did, again, 83% if you're A and B, but if you're C and D, you were down by 27% at 5 years, and then, 55%, or I'm sorry, 45% if you were at 10 years. And then if you had lymph nodes or not, if you had lymph nodes, you did much, if you did not have lymph nodes at presentation, your overall survival was much better than if you did. So all these are tricks to help us on trying to decide how to help our patients best. And again, because this tumor is so rare, it's important to have that the team effect. So this is the overall sort of summary here, but I wanted to spend a couple of minutes because what we're trying to do at Ohio State is also look at things from a molecular standpoint. And we were fortunate enough for those 38 patients to actually have all the tissue from those patients. So we can study at the DNA and RNA level what is going on with these cancers. And we also have 8 patients, we're so fortunate about this. We also have 8 patients where we have the patient had surgery, then radiation, then unfortunately recurred and needed another surgery. And so we have that tissue as well. So we're looking at this now. We've applied for a Department of Defense grant to help us with this, but with the team of Dr. Pervidello, Dr. Corral, myself, and Dr. Wakely, our pathologist, we're looking into this a little bit further to see if there's some molecular things that we can do. So we can look at things from DNA standpoint, from an RNA standpoint, from a protein standpoint. And just to note, Dr. London is also collaborating with us on this. And so there are reports where people have looked at this, and you can see Cell, Nature, these are our top journals. And what is exciting for us is we're really hoping to contribute in a positive way to the literature. In the Nature paper, there was 13 samples. In the Cell paper, there was 18 samples. And we're hoping with 39 that we can really help, and especially those folks with the before and after, meaning they were treated with the radiation and then they came back. And the idea is, can we figure out some key things that'll help us understand why those patients didn't do as well, so we can really personalize our treatments. So I want to end with this picture again, because this is really the key. Why are we doing all this work? Is to help the patients. Without this team, I don't think we can do a good job. And I think that's true, and everybody will say across the board. So it's the village that we talk about here. Dr. Corral leads our skull-based team. Dr. Pervidello is our neurosurgeon. So these two are a strong team and have international reputation. The rest of the folks here, Dr. Mladkova is our very capable resident who also has big data ability, and then Dr. Wakely is our pathologist. Dr. Bonomi is our medical oncologist. And with that, I just want to say thank you. And I look forward to talking to whoever has any questions or wants to discuss.
Thanks so much. That was fantastic. It was great to hear perspective from a radiation oncologist who has obviously significant experience in the area, and we're looking forward to seeing what you find with your molecular analysis from those samples.
Thank you so much for the opportunity.
Of course, you're welcome. Our last speaker this morning before we go into our breakout sessions is Dr. Fludas, who is a medical oncologist and a colleague of mine here at the NIH and at the NCI. And he's going to talk to us from a medical oncology perspective.
Yeah, can you see my slide, the presentation mode? Yeah,
yep,
great,
perfect.
Thanks. So, hello there. I hope everybody's having a great day today. I'm Haris Fludas, and I'm a head and neck medical oncologist and immunotherapy clinical researcher with the National Cancer Institute in Bethesda. There I'm working with the head and neck surgeons of the NIDCD, such as Dr. London, and having said that, I'd like to thank him for this opportunity to address this wonderful meeting. It's a great pleasure to be here. Now, after a set of fantastic talks about the multidisciplinary discussion and management of olfactory neuroblastoma, I'm going to be sharing some thoughts about the medical oncologist perspective on olfactory neuroblastoma. However, from a more abstract vantage point, I won't be discussing specific treatments so much, and the reason for this is part of the discussion, I think. So, when does the medical oncologist get into the picture for patients with olfactory neuroblastoma? At the time of primary diagnosis, as the previous discussants mentioned, the medical oncologist is way less involved in care decisions as compared to the surgeons of various specialties and the radiotherapists and other specialists. But the medical oncologist becomes way more involved in the care of recurrent disease, especially if the recurrent disease presents at a site that is different than the primary. And what is the primary task of the medical oncologist? As we may know, at the core of it, it is to treat the patient, which involves selecting the appropriate treatment for the particular patient, given the individual characteristics, current condition, medical history, and looking to maximize the benefit without causing inadvertent damage. So that may be caused by well-intended overtreatment and consequent long-term toxicity. So in addition, as one would expect, we also coordinate the management of complaints and complications that come from the treatment and the disease. And once the treatment is completed, we participate in the follow-up of the patient longitudinally. So how about the treatment selection? The term selection implies the availability of choices. In the contemporary medical oncology paradigm, these choices will have started as results of extensive lab research with tumor cells, part of what we call basic research. And also these choices will have their efficacy validated in clinical trials, part of what we call clinical research. And this will lead to FDA approvals and to guidelines that are endorsed by the oncology professional associations. So every colleague that might have a patient with a particular disease can look up to the approvals, to the guidelines, and choose a treatment based on evidence. But in the domain of rare malignancies, and in particular olfactory neuroblastoma, the situation is different. There are no guidelines or approvals pretty much, and the available evidence is quite limited. That is not surprising because, as you've heard so many times today, the disease is rare and the patients are dispersed across the United States, making things even more rare. So, in turn, this makes the systematic and formal testing of treatments in the context of clinical trials very challenging. In my experience, it's quite more difficult to collect the evidence needed for supporting a clinical trial in olfactory neuroblastoma in comparison to a disease that is more prevalent, where you have previous evidence, systematic approach to cite and say, I want to do this for this and that reason, and I have this evidence. So any regulatory body has the ability to say, yes, go ahead. So it then becomes a catch-22 situation. You need research to acquire the knowledge base that is required for further advancement of research and clinical care. So for olfactory neuroblastoma, systemic treatments for the medical oncologist are cisplatin-based chemotherapy regimens, and pretty much come from similar diseases, similar in the sense of pathology, and it's a quite limited field. Now, these treatments are based on looking at descriptions of groups of patients, usually from a single center, documented over decades, and therefore the care is heterogeneous and may be outpaced by advancement in surgery, imaging, and newer treatments. So when you look to the literature, you might say, you know, survival stated here is this, but this was treated 20 years ago, and CAT scans were different, PET scans were different, everything was different. Does it apply to my patients today? When will I be able to see the outcome of what is applied today? And as for newer treatments and innovations in therapeutics, they get to be tried perhaps in individual patients, and they may or they may not get published. And so not getting in the literature is a shame, because this information is invaluable for further guidance. Now, what is the outlook? There is no doubt about it that improvement of clinical care for patients with olfactory neuroblastoma requires taking research results from the lab, translating them to treatments, and testing these. So can we improve our basic research? Luckily, in the previous talk, there was an introduction to this, and I can agree so much with it that certainly modern methods of molecular research are quite powerful. But for a thorough multi-layered examination, we require adequate tissue in various stages of the disease, as again was talked before. And we do need samples from a lot of patients, because samples from more patients allow for increased discovery power, statistically speaking. So one might hope that eventually there might be a centralized repository of biospecimens and clinical annotations, facilitating research in the way that the big biology projects such as the Cancer Genome Atlas have accelerated discovery. And about clinical research, can we improve it? Well, while it's true that dedicated clinical trials for rare diseases are challenging, they're still absolutely required. We can't go on with case reports. So maybe smaller investigator-initiated trials are a way to go forward, since they are more feasible from a design standpoint, but participation is key to make sure that they come up with a conclusive answer. And this is where patient communities and communication networks are a key component to achieve a critical mass that would allow this community to escape the catch-22. So, and with that, this talk is done. Thank you. Thank you for the opportunity to discuss.
Thank you so much, Dr. Flutas, and thank you so much to all of our physician speakers this morning. I really enjoyed all of your talks and the insights that all of you provided in the multidisciplinary treatment and management of esthesioneuroblastoma.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4CANCER.